The highly anticipated National Health Insurance Scheme moves a step closer to reality today when it comes before Cabinet. Joining us in studio to tell us more is Alex van der Heever, his Old Mutual Chair of Social Security at Wits. Thanks so much for joining us this afternoon, Alex. Well, we've got Health Minister Aaron Motsoaledi expected to reveal the long-awaited detail of the National Health Insurance Scheme and how exactly it's going to be rolled out in South Africa. What are your broad expectations?
Well, my expectation not that high. I think the original proposals were technically rather doubtful. But what we're probably going to see is recommendations for the long-term restructuring of aspects of the public sector which are required. The question is whether they're focusing on the things that need to be done. And but I do not expect major changes to be announced for what would happen within the next 3 to 4 years.
Yeah. When it comes to things that need to be done, I mean, it's got to be coupled with an improvement in the quality of healthcare in the public sector. So the question is, are we really equipped to go down this path, whether we're looking at skills at hand, finances that are ready to fund this? Because this is, I've come across an article saying potentially the most expensive policy to be advocated by the ANC so far. Do we have the resources, capacity to actually go down this route?
Well, we don't have the resources to implement what was originally proposed. I think that a lot of those pronouncements and documents that were produced at a political level were technically nonsense. The certain of the constructs that were discussed are in some cases valid, but in many cases they're not the required reforms for now. So I do not expect that the fully expensive proposal, the very expensive proposal, and will actually materialize. If the proposals as originally set out were introduced, they would be a very big problem for South Africa's economy, not for our health system, which won't necessarily improve, but they would definitely be a problem for the macroeconomy.
Let's take a look at how so and where these holes lie. And of course, we're running on the premise of that original document because we're still waiting the detail on the new proposal.
Yeah, if the current flaws in the public health system are quite deep and have arisen to a large extent in the last sort of 15 to 16 years. They involve, to a large extent, a breakdown in the governance and accountability framework of the delivery system. If you looked at the recent reports on maternal and newborn health that are coming out, essentially that's an accountability problem. It's how services are held to account for providing care. It's not about the absence of staff. It's not about the fact that we don't have enough resources in the system. It's about the fact that they're not being well managed. And there is no proposal that I've seen to date that actually meaningfully tries to address those things in a realistic way. And one of the big problems in addressing that is that there are a lot of vested interests against putting in proper governance and accountability mechanisms in the public system. And therefore, I would expect in this report for those kinds of recommendations to be wholly absent. Yeah. And if they are absent, it means that there is no serious consideration of what is currently deeply flawed in the public system.
And then we've got commentary, coming through from the health minister saying that, the current model requires hospitals be run like businesses has to go. They're not business entities, they're social entities. And when you think about running a business, it's got different ethics altogether. What do you make of that kind of rhetoric or commentary that's out there?
I was quite mystified by it. I did read it. The public sector hospitals are certainly not run like businesses. They're not even run like public entities. The problem in many cases is that perhaps it appears to be referring to the fact that people who are not doctors were put in charge of hospitals. Well, the entire French health system is based on that. They do not appoint doctors to run their hospitals, and yet they've rated one of the best health systems in the world. And their public hospitals are run extremely well. So the choice of whether or not you have a person who's qualified to manage a facility in charge or a medical doctor is neither here nor there. It's not the issue. The problem is who is appointed and why are they appointed to run hospitals and how are they held to account. Our current organizational structure and corporate governance structure is from the Dark Ages. And it's a politicized model which allows these people to be appointed by political structures, and they become caught up within the political dynamics of the provinces, which means that the appointments and how they're held to account has very little to do with patient care. And that is actually the central problem. And it's not that school teachers are appointed to run hospitals. The question is, how does that happen? That doesn't change by changing the qualifications or making it a medical doctor has to be there, because a medical doctor appointed in the same way will operate in the same way as a school teacher appointed.
Well, let's bring in a private voice to this discussion at this stage. Joining us on the line from Cape Town now is Roly Buys. He's Funder Relations and Contracting Executive from Mediclinic Southern Africa. Thanks so much, Roly, for joining us this afternoon. We've been just debating, the kind of rationale behind a national health insurance scheme, what would be viable, what would not be in South Africa, implications for the private healthcare and players like yourself as you see it.
Well, good afternoon, and thanks for the invitation. Well, I think very much like Alex has just said, we actually have to wait and see what the document will show. At this point in time, I guess it's really going to be more to principles and to the sort of things that we saw in the ANC document in September last year, and what we really need to see is far more meat around the proposal in terms of, what the structures would look like, what sort of systems would come to play. All of that sort of stuff really has to be fleshed out in a great more detail before you can make any sort of opinion. It seems to be that there's a primary healthcare model being proposed, which is very regimented. You have to see the nurse, and then you go from the nurse to the doctor. And that kind of proposal seems very much in conflict, I think, with one of the fundamental principles of freedom of choice, for example. So, as I say, I think we need a lot more detail before we can make any sort of judgments. And my guess is from the hospital environment that really ours will be a contracting basis to provide services that they might need from time to time. But all of that also hangs onto the question of the quality accreditation system, which they also have to establish first. Because in one of the previous documents, they gave a very good indication that they wouldn't be contracting with anyone that wasn't accredited. So we need that leg as well. So, I tend to think there's lots of building blocks that need to be built before we could get an answer to that.
Okay, well, we've got Alex with me in studio, as you know, and he's got a question for you, Roly.
Well, it's not necessarily a question, it's a comment on the issue of accreditation and the accreditation framework itself. There is meant to be an Office of Standards Compliance that is proposed, and this is normally a good idea because it deals with quality assurance within the system. But it appears as though the proposal is being created in order to create some form of contracting relationship between the state and the private sector and the public sector. That's a very, very long-term model. The issue is we've got very big problems right now on quality assurance. But the proposed governance, corporate governance structure for this Office of Standards Compliance involves essentially a ministerial appointment, a politicized structure, which means that there is very great danger that the allocation of accreditation, which will now have very big financial implications and can affect people's contracts with the state, or even whether or not they remain viable quite outside of it, because there's no reason why an institution shouldn't be accredited regardless of whether or not they do contract work for the state. They shouldn't be allowed to operate if they are providing poor services. Now, you can't have a politicized structure that's allocating licenses, that's allocating accreditation, and that's doing quality assurance, because it will turn a blind eye to anybody with a political connection who is now offering certain services, and it will eliminate people from the system who, are not essentially doing what they're meant to be doing at a political level. So that's a major concern. Those kinds of structures, as part of the overriding proposal, are extremely problematic and really need to be removed.
Oh, well, certainly this topic that we cannot get completely in depth with over the course of a 7-minute interview. It's discussions that I'm sure we'll be having as we see details around the National Health Insurance Scheme come to the fore. Thanks so much, Alex, for your time this afternoon. Of course, Alex van der Heever, Old Mutual Chair of Social Security at Wits University, and then Roly Buys, Funder Relations and Contracting Executive from Mediclinic South Africa, joined us on the line there as well.